amazing to have this day here today. As Sally said, and Sid has said, it's 4 years since we held the first one, and the advancements in Kabuki and research that's happened in the last few years is just fantastic. So I'm delighted to hear about what the rest of the day is going to hold. So Sally's introduced me. I am an ENT surgeon, paediatric ENT surgeon in Middlesbrough, part-time, and I'm also part-time mum and PA to Emma, and that is why I'm part-time, because she has so many appointments that it's not physically possible to get it all in with a full-time job. And she's also 10 today, so happy birthday to Emma. She has given me permission to come, but I will be dashing off at the end of the day to get home before she goes to bed. So really I wanted to talk a bit about hearing and the ear problems that you have in Kabuki syndrome, and I thought it might be useful to just kind of talk about hearing loss and how we investigate it, what kind of problems they can be, and these are in children without Kabuki syndrome as well. But I thought it might be useful to show you about some of the pathways, talk about some of the diagnoses and how we manage them, some of the terminology. So if your child doesn't have any problem with their ears, you can go to sleep now, get another coffee. This is all going to be about ears for 20 minutes. And then Melanie's going to come and talk about cleft palate, and I've already been quizzing her this morning about Emma, so that's been really useful to me. So I think hearing is so important for children, and anybody really, isn't it? Because if you can develop speech and you can hear, you can make yourself understood, and you are less vulnerable in life. And I think it gives us power, you know. And so I think it is so important for children to be able to hear and to be able to speak. And we know that hearing loss affects your ability to learn language, particularly in the first 3 years of life. It's really important that we hear, because that's when we're picking up our speech. And we also know that there's much more impact of hearing loss on speech development and understanding, particularly in children with other developmental problems. And I've just come from Glasgow, where I was talking about Down syndrome and the problems with hearing in that. And there's lots more studies that have been done in Down syndrome, because obviously it's much more prevalent than Kabuki syndrome, and that shows that the hearing loss and the impact on speech is disproportionate to their IQ level. So it's really important that I think that we pick up on this hearing loss, because it's going to affect their social skills, their confidence, their literacy, and we need to make sure that people don't assume that their speech delay and their lack of understanding is just due to their developmental delay and is not actually a consequence of their hearing as well. So when we come on to hearing loss, paediatric hearing loss, it's diagnosed in 1,000 to 2,000 babies that are born, and that's picked up with neonatal screening. And you know, the papers say that 24 to 65% of people with Kabuki syndrome have hearing loss, but those numbers are really difficult. You know, we know how rare Kabuki syndrome is. Studies on hearing loss in Kabuki syndrome are even more rare. And when you look at any papers that have been written about Kabuki syndrome and ear problems, they're all really small scale studies. They're collections, you know, they're one hospital's collection or one area's collection of Kabuki syndrome. And so there'll be 20 patients or 30 patients. And you can't make wide kind of conclusions about prevalence of things from such small studies. So, you know, who knows what those numbers are? But I think these kind of, you know, the advances that we're seeing now is, and the collaboration of people worldwide coming together are going to help us get better studies and better figures so we have a better idea. So in general, if you're talking about hearing loss can be congenital, so we can be born with it, okay? And that can be due to a genetic problem, which might be related to a syndrome or a non-syndrome, or it may be due to infection antenatally, so things like mumps, measles, rubella, CMV. These can all cause a congenital hearing loss. Or it might be acquired, it's developed after they're born. And again, this could be due to infection, although same infections, meningitis, got a higher risk of hearing loss with it. It might be anatomical, about the way the ear is formed and the eustachian tube that we're going to talk about. It might be related to trauma, or it may be due to certain medications which can cause hearing loss as well. Hearing loss can also be described as being conductive, sensory neural or mixed, and we'll talk about the difference between those. And it might be mild, it might be moderate, it might be severe, it might be profound, which means there's no hearing loss, no hearing at all. It might be one-sided, it might be both sides. And then it might be fluctuant, so it may, change over time. It might be progressive and get worse. It might be static, but it might just be temporary. So there's so many different parts to that hearing loss. So this is just a short video, hopefully, about, good, and the volume is not on, about the hearing pathway. So sound comes into the ear. I don't know if there's a laser. Oh, no. Oh no. There isn't. Oh, this one. Okay. Comes along the ear canal to the tympanic membrane and vibrates the tympanic membrane. And that vibration then is transmitted through the bones of hearing. So we've got the malleus, which is like the handle. We've then got the incus. That was so nice to play it then, wasn't it? You could write about that. Which is the anvil, and then the stapes, which is the stirrup. And then this movement here of the stapes onto what we call the oval window transmits that movement into the cochlea, which is this kind of snail-shaped structure. And the movement of that fluid then moves the hair cells in the inner ear, and that sound and that movement then is changed into electrical energy, which then goes off up to the brain. That's the complicated bit done. Okay. So how do we pick up hearing loss? So every child that's born in the UK, and many other countries, but not completely worldwide yet, goes through the National Hearing Screening Programme. Okay, so all babies before they leave hospital will have a hearing test, and that's usually done with electrodes or a probe into the ear, and that will pick up a severe hearing loss, a sensorineural, a nerve-related hearing loss. After that, how is hearing loss picked up? Well, health visitor checks, the health visitor comes out 6 weeks, 6 months, 1 year, 2 years. The health visitor will inquire about any hearing loss. If there's concerns, then they can be referred in for a hearing test. After that, when really it's about parents going to the GP and saying, I don't think my child's hearing very well. And usually the GP will watch and wait for a little bit because, as we've said, it can be temporary hearing loss, it can fluctuate. So it may be a little bit of time before the GP refers. You've got to get your appointment in at the GP first, so that might take a little while too. And they can refer you directly into paediatric audiology. And that's important that they go to paediatric audiology rather than ENT, because my waiting list at the moment for a new patient is probably about November, December. And you don't need me, you need a hearing test, and hearing tests tend to be much quicker, and sort of in our region it's about 6 weeks to get a paediatric hearing test. So make sure your GP refers you to an audiologist, not an ENT surgeon. You don't need the ENT surgeon yet. And then I put question mark school. So previously all children would get tested when they were in reception. But this is disappearing now, and certainly where I live in North Yorkshire, there is no longer school screening anymore. It's just becoming unviable, it's too expensive. So your child may still get tested in school, but in a lot of areas they're not. And then surveillance programs. So there are certain conditions that are more likely to be associated with hearing loss. And therefore there are guidelines within each sort of region of what children will have annual screening, 6 monthly screening. So Down syndrome, for one, they will all go through regular screening. Any child with a cleft palate will have regular audiological follow-up. And actually in our region, Kabuki syndrome is on that list. But there isn't a national guideline that says exactly which syndromes should be tested. And depending on how old they are is how they get the hearing test done. So if they're at birth or very young and they can sleep, then you may do a test with an electrode. But what you really want is behavioural testing. So this is what you would have done first of all. So this from about 6 months onwards, where the child is conditioned that when they hear a sound, if they look over at some box, something will happen. Okay, and then you'll play sounds to them at different frequencies and different loudness levels and see if the child moves. I think this is where the fear of clowns came from for children, because often there's a clown in them dancing around. When they get a little bit older, past 2, you can do something called play audiometry. So again, the child is conditioned that when they hear a noise, either in the room or with headphones on, if they'll wear headphones, and then you can do ear specific, they will do something. So in this one, they're putting blocks into the box. And then as they get older and into adulthood, you get the headphones on, you hear the noise, and you press the button. But these all rely on the development of the child. So in order to be able to do any of the behavioural ones, the child's got to be able to sit up and they've got to be able to turn their head. So for our children that have got poor tone, it can take them longer before they're sitting up and before they can do these tests. So sometimes it can take quite a while before you can get full hearing tests on them. And when you get your hearing test, you may have all come home from your hearing test appointments with these graphs that you think, oh my goodness, what does that mean? They're plotted on here as the different frequencies. So these are the low-pitched sounds, these are the high-pitched sounds, and down this side is how much noise we have to put into the ear before you hear it. So we say that 30 decibels is the quietest you can possibly whisper. Okay? 60 decibels is normal speech, and 120 is an aeroplane taking off on a runway. And normal hearing is anything above 20. Okay? Mild is 20 to 40, anyway, you don't need to know the levels, but this is progressively as it gets worse. Down here, we're in cochlear implant territory. Up here, we're more in grommets and hearing aids, and if we're normal, then perfect. So, if we think about the different types of hearing loss, conductive hearing loss, if we split the ear up into the outer ear and the middle ear, so this is up to where our little stapes was pushing onto our snail-shaped salve, which has been opened up. This is where the sound can't get through down the ear canal to the tympanic membranes through the bones of hearing. Something is wrong in this pathway. And this is the most common reason why children have hearing loss, and also one of the more common reasons in Kabuki syndrome. And this could be wax, okay? If wax is blocking here, then the sound can't get through. And I put that there because actually it's not common that wax causes a significant hearing loss. People, and doctors will look in here and go, oh, it's wax there, that's why they can't hear. Actually, wax has got to be really impacting, closing all of that ear canal off before it causes a hearing loss. So don't assume that because they've got wax that is necessarily causing much of a problem. The main reason why children have conductive hearing loss, and particularly in Kabuki syndrome, is something called otitis media with diffusion, or OME, or glue ear, as we're more commonly used to hearing about it. And we're going to talk about that more. It might be secondary to an infection, so an infection in the middle ear, otitis media, which is behind the eardrum, can also be in the ear canal, and otitis externa, but not so common in kids. A hole in the eardrum is going to stop it vibrating as much, so that's going to affect your hearing. And you can get chronic problems behind the ear, which cause hearing loss as well. And if you can't see any of those things, there's no hole, there's no wax, there's no fluid, then it must be something wrong with the bones of hearing. And that has been picked up in Kabuki syndrome, and I'm pretty sure that's why my daughter has got her hearing loss. So glue ear, most common reason for children to have a hearing loss. And it's multifactorial. Mainly, it's about the eustachian tube. So the eustachian tube is this tube that connects the back of your nose to your middle ear, and it's there to equalise the pressure behind your eardrum. And you'll know about your eustachian tube when you go in an aeroplane and your ears pop. That pressure change hasn't quite caught up with you going up in the aeroplane. And in children, this eustachian tube's not developed very well. It normally develops by the time they're about 8, so they are more prone to glue ear. And what happens is they have negative pressure behind the eardrum because that tube's not working properly. It sucks the fluid out of the cells and they get fluid behind the eardrum. And then that stops the eardrum moving as well and processing the sound through it. And it's called glue ear because it is thick like glue, really thick like glue. Okay, so it's a developmental problem in all children, the eustachian tube. It can also be affected by household smoking. If you have recurrent ear infections, then you can get left with some fluid afterwards. But it's really strongly associated with cleft palate, because if your muscles aren't moving in your palate, it's those muscles that open the eustachian tube. So that's why all children with cleft palate will be in regular clinics with the ENT surgeon in audiology. So here's a normal eardrum looking nice and shiny. This is an eardrum with fluid behind it. I don't know how well you can see it, but it's a bit more dull and suction. And it tends to peak at 2 years and 5 years, and it's usually gone by 8 years. And it will affect hearing, and that will therefore impact on speech delay, particularly in this younger group who are developing speech at this time. So how do we manage it? Well, initially, we do nothing, because it can get better on its own. Okay, so the NICE guidelines, the National Institute for Clinical Excellence, says we should repeat the hearing test at 3 months' time. Do nothing on that first one. Well, who knows how long you've waited for that first hearing test? That's some of the problems. We certainly looked at our data, and I think people were waiting a couple of months to get into their GP, then they're waiting several months to get their hearing test, then they've got another hearing test at 3 months, and then eventually they get referred into ENT, and after then it's 6 months to see ENT, and by the time they get any treatment for it, they're a year down the line. I mean, that's not satisfactory. So we've changed our process on that. But that's what's been happening. There's a lot of children out there, particularly through COVID, who've missed that opportunity. Our waiting lists are so long now that some of these children have grown out of their glue ear by the time that they get to the top of the waiting list. So we repeat the hearing test at 3 months. And then we're going to treat it depending on the child. We don't want to treat a hearing test. We don't want to treat a picture of an eardrum or what the visualization of the eardrum looks like. It depends on the child. How is it affecting them? And the options that we've got are hearing aid and surgery. And we should probably go to surgery because 95% of children who have glue ear will have surgery. And this is across the board with children. What we do is we put grommets in. So a grommet is a little tube that sits in the eardrum with a hole in it, and it's not there to drain the fluid, it's there to act as an artificial eustachian tube, because whilst that hole is there, you can't get that pressure change, so the fluid doesn't get sucked out of the cell. It stops it coming back. We take the fluid out when we put the grommet in, we put the grommet in. And immediate improvement in hearing, as Lisa will tell you, because she's recently been through the grommet situation. So it does cause an immediate improvement in hearing. We don't have to wear a hearing aid. But the negative kind of sides of it is your child's going to have to have general anaesthetic. So depending on the other comorbidities that your child's got and the risk to them of having a general anaesthetic is a general anaesthetic, but nevertheless short. There is a risk of infection with any grommets, and particularly in our children who are more prone to immune problems that can affect them more. And that grommet will last about 6 months. Sometimes it will come out sooner, sometimes it might last for years, but it will eventually usually come out around 6 months, and there's a 3% risk that they may be left with a permanent hole in their eardrum afterwards, which early days is not so bad because it's like having a grommet without a grommet in, but long term they are going to be more prone to infections because of this hole and may need another operation, a bigger operation, to close it off. So grommets is one option, and it's the most common operation undertaken in children. The other option is we give them a hearing aid to try it, so we're not getting rid of the glue, but we're going to amplify the sound so they can hear better. And we might have a conventional behind-the-ear hearing aid, but we don't tend to use those so much. What we tend to use now is these bone-conducting hearing devices that are worn on a headband, and this is a bone-conducting device, so it sits just behind the ear on the bone of hearing. The hearing aid collects the sound, it amplifies it, makes it louder, and then it's transmitted directly through the bone to the inner ear. So it's bypassing that outer ear, that middle ear, going straight past that fluid, or you can see it at the top, and it's going straight to the inner ear. And these are really good, actually. They're tolerated really well. They're good because even if the hearing fluctuates, which it does in glue ear, if you had a normal behind the ear aid, they'd have to keep adjusting it every time it changes, and how often is that going to be, because you're only going to get your hearing test every 3 to 6 months. This will adapt for whatever the hearing loss is. Doesn't need any changes. The negative side of things are your child may not wear this. They might not tolerate it. Some children won't wear glasses. If they won't wear glasses, there's a chance they're not going to wear this. It's the cosmesis side of things. Not so bad for girls, but the boys are getting slightly older. They don't want a headband on. I mean, they do come in a range of colours. They don't just have to be pink. But your child might not, want to wear it as they get older. But this is the way that we're seeing more things going. If it's going to be a permanent thing, so maybe it's different, or it's a problem with the bones of hearing or something like that, you can have a permanent one of these without the headband. So you have a screw put into the skull, and then you flip the hearing aid directly onto that screw. And that works better. You get better results from it, and you don't have to wear the headband. The other thing that you can do, not a huge amount of evidence in it, but it doesn't do any harm, is something called an Otavent. And you can buy these off Amazon, and this is just a little device to try and improve that eustachian tube function. So what you do is you hold it to your child's nose, close off the other nostril, and get them to blow it up. And by doing that, it opens up that eustachian tube and helps to try and get rid of that fluid. It is really hard. Okay, I've been doing this a few times, so this balloon's got a bit laxer now. But it's quite hard work, So this, I'm not sure that my 10-year-old would manage that, I have to say. But it is something that you can trial, and this is part of the NICE guidelines. So there we go, Otavent, about £3 on Amazon. So ear infections, common in all children, okay? But they might get a hearing loss after that ear infection because they can end up with some fluid afterwards. So more common if they've got immune problems, which we know is an issue in Kabuki syndrome. Usually starts with an upper respiratory tract infection, then they get severe pain in their ears, one or both sides. And you can see why, this is an eardrum here with pus behind it, pushing on that intact eardrum. So it's really painful. And then what happens is it'll either get better or it might pop. And if it pops, the ear starts leaking, but the pain relief, because you've lost that pressure. And a lot of the time we just give symptomatic relief because it's usually viral, but if it persists, then we might be giving antibiotics. Rarely, the infection can spread and go to the bone behind the ear, something called mastoiditis. So this is common in all kids, but more common in Kabuki syndrome, and one of the main causes that causes the hearing loss. So a lot of children will, all children will ultimately get an ear infection at some point. Some might get 1 or 2 a year, that's okay. But there are children who get them a lot each year. And that means that they're on antibiotics a lot, they're off school a lot, they're in pain a lot. It's not nice. So what can we do to help prevent it? No smoking in the house, breastfeeding. It's a bit late down the line, isn't it? When you're, I'm 6 now, never mind, I missed that opportunity. I'm not judging anybody. I did not manage to breastfeed her. My life was far too stressful when she was in the neonatal unit. That was the last thing I could manage. So no judgment here on breastfeeding. Immunisations, keep them up to date with their immunisations, so they're not picking up as many coughs and colds and things. If you're not getting many, you just treat them as they occur. But if they're getting more than 6 a year, then that's the time that we would tend to intervene. And there's no evidence out there in the medical literature, despite the fact ear infections are really common in kids. We don't have evidence on what we should be doing with them. But what we tend to do as paediatric ENT surgeons is we might think about whether there is any underlying immune problems that we don't know about and do some blood tests. But mainline treatment will be some prophylactic antibiotics. So an antibiotic that they're on all the time for several months to try and prevent the infections happening. And we usually give them for sort of about 4 months, and often that is enough to stop the infections when the antibiotics finish. It's almost like sometimes I think they get these infections, they have antibiotics, it simmers them down, but they're hovering around in the background and you're just doing this all the time. But giving them a good whack of low-dose antibiotics for a few months will often just stop them long term. And the other option that you can do is put some grommets in. So sometimes actually putting the grommet in will prevent the infections. Sometimes grommets cause infections. So sometimes a bit of a chicken. There is no right answer to it. Nerve-related loss. So this is uncommon, much less common in children. It can be picked up at birth with our neonatal screening, or it can start in childhood and progress. Inner ear abnormalities that have been identified in Kabuki syndrome, so our problem with sensory neural loss is going from our snail-shaped cochlea up towards the brain, so that the nerve that goes off up to the brain. So this is, if you've got a problem here, that gives us a nerve-related hearing loss. This pathway is all fine, something's going wrong in the inner ear. And these sort of malformations can happen in any child, and some of them are more common in certain syndromes, but these are the ones that are being picked up in Kabuki syndrome. And how we manage it, again, is going to depend on the level of hearing loss that we've got. If it's only a mild loss, then a hearing aid may not be helpful for it. It might cause more problems than good. But there's no operations that we're going to be able to do to make this better. We're only going to be able to amplify the sounds and make things louder for them. And our bone-conducting hearing aids are not so good for this, because if our problem's in here, it doesn't matter if we make the sounds louder to it, it's this processing that goes on. These can work if your other ear is working fine, and you've just got one ear that's got a nerve-related hearing loss. The sound then goes across the skull into the good ear, so it will work for a unilateral or one-sided nerve-related hearing loss. But otherwise, we need a behind-the-ear aid, which is simply making the sounds louder into the ear. And if it's really bad, then a cochlear implant, which is an operation, but it's really just an operation to give you a hearing aid. So what can you do, and what should we do as parents to try and help things? Diagnosis is the most important thing. If you think your child's got a hearing aid, take them to the doctors, get that appointment in, have a little period of watchful waiting first, so you can say that you've done it, because that's what they're going to make you do anyway. So you can say, well, I've already waited, thank you very much. I have a hearing test, please. Otobent, nothing to lose on an Otobent. If your doctor looks in the ear and says, yeah, I can see there's some fluid there, we could try that. Wax, get rid of the wax, because otherwise people will start to blame it. So what could you do to help with the wax? Olive oil drops, doesn't need to be anything fancy. Tesco Savers, doesn't need to be Tesco Finest, doesn't need to be anything fancy. Just some olive oil drops. Put as many as you can in the ear, give it a little shake, a little pull to get the ear full of it. Bedtime's the best, when they're lying down, ear up, fill it up full of olive oil, 4 to 6 weeks. twice a day. It will just help soften that wax and it should come out on its own. No cotton buds, okay? I forgot to put my cotton bud picture up there. I'm glad I remembered it last minute. All cotton buds do is shove wax down deep in the ear where it can't get out. It might come out of your ear looking really good, like you've done a really good job with all that wax on it, but actually you'll be pushing more down your ear than you are getting out. So no cotton buds. Sodium bicarbonate is another type of drop that you can use to get rid of wax. It fizzes up, so some children don't like it, but that's another option. Let school or nursery know, so that if you think there's a problem in the classroom, often they're the ones that pick it up and tell you, but so they can put them at the front of the class. They can position them so that if we know that one ear is working better than the other, they're speaking at that side of the patient, that side of the child. Tell them to speak directly to their face, rather than talking stuff from behind, so they can lip read as well. Once you've got that diagnosis, and I think a lot of doctors forget this, the audiologists are much better, but we as doctors are a bit rubbish, and actually the form is really quite cumbersome. So, is referral to the teachers for the deaf. They are brilliant, they will go into the school, they will educate the teachers about positioning, they will then speak to them about whether they need extra time for certain things, for exams or things like that. They will also teach the teachers how to put the hearing aid on. You should see some of the positions that Emma has come home in with this hearing aid on, despite the fact I've sent in photographs, but they will teach them about those kind of things. If your child gets recurrent ear infections, keep the ears dry. So cotton wool with Vaseline if you're going in the bath. You can buy molds, silicone molds on the internet, just to try and keep those ears dry. Soapy water's the worst, and if they've got an ear infection, just avoid swimming. And immunisations, keeping them up to date with their immunisations. Childhood immunisations can be really helpful.